Alright, this is going to be a lecture for the cardiac exam for med-surg. Just going over the PowerPoints, not ATI. Alright, so starting with chest pain protocol. As soon as the person is having chest pain, if they're in the hospital or at home, you want to stop activity, place them in the semi-Fowler's position to reduce myocardial oxygen demand. Now this other stuff is more in hospital. You want to immediately put on oxygen because that will reduce their demand. Have them chew about 325 milligrams of aspirin. You always want to be doing their baseline vitals, have IV access, and put on an EKG, usually if they're coming into the ER in the first 10 minutes. And then, oxygen, aspirin, then we're going to be doing one nitroglycerin sublingual. If the pain does not subside, you can do that up to 3 times in 5-minute increments. You want to always check their blood pressure between each nitroglycerin because it can force their blood pressure to bottom out, and if that does happen, you want to get some fluids into them that can counteract. This says EKG when pain-free, but the book also says EKG in 10 minutes of having the chest pain if they come into the ER. They might need IV morphine titrated for pain relief. Do vital signs of that as well. I feel like I'm going to sneeze, I'm sorry. So oxygen, aspirin, nitroglycerin, morphine. Yeah. All right. You want to reduce their anxiety, so you want to use a calm manner, use stress reduction techniques. We can do some patient teaching. This is kind of after the fact of the treatment, addressing their spiritual needs, family and patient needs, some teaching, lifestyle changes and reduction of risk factors, explore, recognize, and adapt behaviors to avoid behaviors to avoid, and to behaviors you want to do to reduce the incidence of episodes of ischemia. You can do teaching regarding the disease process, medication, stress reduction, when to seek emergency care. Alright, so chest pain is kind of on the spectrum of acute coronary syndrome, or ACS, which includes myocardial infarction. So that is when an area of this ACS overall is an area of the myocardium being permanently damaged, usually caused by reduced blood flow in a coronary artery due to a rupture of an atherosclerotic plaque and subsequent occlusion of the artery by a thrombus. Which is a clot. So in unstable angina, the plaque ruptures, but the artery is not completely occluded. So there is still blood flow, but they're having that chest pain. That's why unstable angina and acute myocardial infarction are considered the same process, but at different points on the continuum. When the plaque does rupture and the thrombus formation results, that can cause the complete occlusion, leading to ischemia and necrosis of the myocardium that is supplied by the artery. So the term acute coronary syndrome includes unstable angina and enstemies and stemies of the myocardial infarction. Myocardial infarction can also be caused by vasospasms, reduced blood flow from decreased oxygen, and increased oxygen demand, which can happen during cocaine ingestion or if you're tachycardic. So there's they use the term time is muscle because it's very important in of early detection to prevent damage to the muscle. The area of infarction develops from minutes to hours. So as the cells are deprived of oxygen, ischemia develops. cellular injury occurs, and the lack of oxygen can result in infarction or the death of cells. So yes, time is muscle, because it's very urgent for people to receive care. So there are different descriptors that can further identify myocardial infarction. For example, the NSTEMI and the STEMI help identify the location of the injury to the ventricular wall. I'm sorry. The type is NSTEMI and STEMI, and then we can also identify the myocardial infarction by the location of injury. So we can say, okay, anterior, inferior, posterior, lateral wall, whatever. And the point in time of with the infarction took place. So you can say it's acute, evolving, or old. So those are just descriptors of the MI. Again, that's the NSTEMI, STEMI, the location of injury, and then the point of time of the process. So to help us do that, we can use an EKG, which usually identifies the type and location of the MI. So the type would be non-ST elevated or ST elevated coming up on the EKG. That's that NSTEMI and STEMI. And other EKG indicators, such as the Q wave, and patient history to identify the timing. Regardless of the location, the goals of medical therapy are to prevent or minimize myocardial tissue death and prevent complications. All right. So this is just kind of a recap of myocardial infarction. 80 to 90% reduction in the blood flow through the coronary arteries, which leads to ischemia, which can lead to necrosis if blood flow is not restored. That's the death of the tissue. Causes could be atherosclerosis or thrombosis, occlusion of blood flow, coronary artery spasm, platelet aggregation. Around the necrosis is called the zone of injury, and the zone of ischemia is oxygen-deprived cells. Okay, so this is kind of going into a little bit of the treatment. So, again, in an MI, the myocardial cells are completely destroyed. It's caused by the reduced blood flow in the coronary artery due to a thrombus or embolus. I'm sorry. So some clinical manifestations: chest pain that's sudden and continues with rest and medication. So it's a different type of chest pain. So chest pain that occurs suddenly and continues despite rest and medication is the presenting symptom in most patients. Some of these patients have prodromal symptoms or a previous diagnosis of CID, but about half report no previous symptoms. So patients may present with a combination of symptoms, which include that chest pain, along with shortness of breath, indigestion, nausea, sorry, I'm stuffed up, and anxiety. They might have cool, pale, moist skin. Their heart rate and respiratory rate might be faster than normal because their body is just trying to compensate. These signs and symptoms are caused by the stimulation of the sympathetic nervous system. So you want to remember, if your sympathetic nervous system is being stimulated, everything's kind of going up. So your blood pressure is going up, your respiratory rate is going up, heart rate, you're getting that shortness of breath, everything's kind of working a little bit harder, having that anxiety. All right, so in many cases, the signs and symptoms of an MI can't be distinguished from unstable angina, hence the term of ACS, because it's kind of on a continuum. They might have some atypical symptoms, so in the ER, careful assessment is very important. So when you assess, you want to get the history of presenting symptoms, personal family history, especially cardiac history, and get the EKG done within 10 minutes of the ER arrival. So some diagnostic findings. The EKG, like we talked about, an echocardiogram, which can evaluate left ventricle, I saw LV, left ventricle function, echocardiogram, left ventricle function. It can evaluate the function of the left ventricular wall and ejection fraction. We can also do lab tests, so we can do specific enzymes that will be the biomarkers. So, for example, troponin, that is a critical marker of cardiac injury. It can stay elevated for as long as 3 days past the MI. I'm sorry, 3 weeks. So troponin can stay elevated for 3 weeks. Also, we have myoglobin, but myoglobin levels are in cardiac and skeletal muscle, so it's not specific. But if there is no change in myoglobin, then we can rule out an MI. And that peaks about 12 hours, but it does start to raise up about 1 to 3 hours after an MI. And also we have CKMB, which is a creatine kinase enzyme. It's mainly found in cardiac cells, and when it's damaged, the level is also increased. So again, that CKMB also increased. Troponin, it's pretty much the the critical marker we look at, and it remains elevated in the blood for much longer than some of the other enzymes. And then myoglobin, not specific, but negative results can rule out an MI. So diagnostic findings, again, in the EKG, we have the ST elevation, but sometimes you can have the NSTEMI, which is the non-elevated ST elevation. So you also might see T wave inversion or an abnormal Q wave, but we're going to go over that in a whole other thing. So, excuse me. All right. So some effects of ischemia, injury, and infarction. There's 3 forms of ACS. We have the unstable angina, which talked about, and that will have no manifestations of coronary ischemia. EKG and myocardial markers show no evidence for an MI, again, because it's not. And then we have the STEMI. So that is evidence of the changes in 2 leads on a 12-lead EKG. There's a significant change to the myocardium. And then we have the NSTEMI or non-STEMI. So that is when the patient has the cardiac biomarkers, but there is no evidence in the EKG of an MI. Usually that's less damage to the myocardium when it's a non-STEMI. And when permanent damage has occurred, there's a change in the Q wave for all future EKGs. That's usually when there's an absence of depolarization from the necrotic tissue. That's when those Q waves develop. And it's ischemia that causes the inversion of the T wave. And the elevation of ST is due to cardiac injury. So that's why when we see that elevation, it's more serious. But again, we're going to worry about the EKG in a different lecture. All right, so clinical manifestations and diagnosis. Again, the latest guidelines for diagnosing a heart attack, would they consider troponin level being substantially higher than normal, plus one of the following. Symptoms of a heart attack, such as chest pain or pain down the left arm, and or worrisome changes on the EKG or imaging test, and or identification of a blood clot in a coronary artery. So we're going to have that increased troponin plus one or more of those things. So the goal is to lay the groundwork for the heart attack care to be standardized, because we want to have great care all around. If you go to Harvard affiliated hospital or a community hospital. Some signs and symptoms you want to look out for. I'm just going to name some based on systems of the body. So cardiac-wise, angina, JVD, increased blood pressure, increased regular pulse, increased or irregular pulse, the ST changes. Respiratory, we're going to have shortness of breath. We might have dyspnea or tachypnea. We might have crackles if the MI have caused any pulmonary congestion. GI, we're going to have nausea, vomiting, diarrhea. GU maybe lower output. Skin, cool, clammy, diaphoretic. Neurologically, we might be restless, anxiety, lightheaded. We have that increased sympathetic stimulation. Remember that. So that kind of also leads into psychology-wise fear, impending doom, denial. All right. So treatment. Very similar to the treatment of chest pain with the mono protocol. So again, obtain diagnostic tests within 10 minutes of admission. I'm just going to flip back for a sec. Okay, so chest pain protocol, that's when the EKG is pain free. I'm sorry. And then if acute treatment of the MI, I guess, within 10 minutes. All right, so we're going to do oxygen, aspirin, nitroglycerin, morphine, like we already discussed. The nitroglycerin decreases the blood pressure, dilates the um, vessels, but it dilates them all over, so you want to remember to monitor that blood pressure. If the systolic becomes below 90, don't give them any more nitroglycerin. It's just going to drop too low. Just go straight to the morphine next. Morphine, we're going to do the IV bolus in adults. It reduces pain and anxiety. It reduces preload. It relaxes the bronchodilators. The bronchioles. To enhance oxygenation. Again, with morphine, you also want to monitor that BP and respiratory because it can decrease. Because it kind of slows things down. All right. So ACE inhibitors, usually used within the first 24 hours. So that reduces blood pressure, and it also helps the kidneys excrete sodium and fluid. So that leads to the blood pressure going down because we're kind of just getting rid of some of that water, and that will also decrease oxygen demand. Okay, so beta blockers are used. It's part of the standard protocol, especially if dysrhythmias occur. All right, so then we're gonna have thrombolytics and PTCAs. So we like to have the PTCAs if you can. So that's when it's done in the cardiac cath lab. So if they do have the ST elevation, they should be immediately taken to the cardiac cath lab for the percutaneous coronary intervention. So they're going to put that sheath in there, and they're going to try to get rid of that occlusion. They're going to open the occluded coronary artery and reperfuse the area. They like to have door, so when you walk in the hospital, to balloon, so when they're making that balloon and opening that occlusion, door to balloon time less than 60 minutes. They want to open that occluded artery and reperfuse the area that was deprived of O2. They're treating the underlying lesion. Now, we also have an alternative thing we can do that does not treat the underlying lesion, but it will dissolve the thrombus, and later they can go to the cardiac cath later, but if you can't get into the cardiac cath for some reason or some protocol, thrombolytics, usually IV or IC infusion. Again, they dissolve and lyse the thrombus in the coronary artery, so blood flow is not obstructed anymore. Ideally, less than 20 minutes, but less than 6 hours from onset of pain is good. But you do not want to use the thrombolytics if you've had any recent trauma, surgery, bleeding, or any bleeding disorders. And this door to needle time, so when you walk in the door to when they're doing the needle for the IV or whatever, getting the thrombolytics, ideally 30 minutes. So some of the agents are used, streptokinase, alteplase, that's usually has less allergic reactions than streptokinase, but it's more expensive. And it's used with heparin to prevent another clot from forming. So thrombolytics, streptokinase, alteplase, and used with heparin to prevent further clotting. So just to kind of go over the core stuff I just said, aspirin administered upon arrival, also prescribed at discharge. ACE inhibitor for patients with left ventricular systolic dysfunction. Beta blockers, definitely prescribed at discharge. Thrombolytic therapy received within 30 minutes of the hospital arrival. If they're going to do a PCI, received within 60 minutes. Statin prescribed at discharge. Some of the statins, they end in statin, so that's easy for their generic. So that's like atorvastatin, pravastatin, simvastatin. You might also see the trade names. Those are Lipitor, Zocor, Pravachol. That's to keep their lipoprotein cholesterol down. They take it at bedtime. You want to monitor the lipids, liver function, creatinine kinase levels. And another statin is clopidogrel. Anyways, it's Plavix. Clopidogrel. That is usually prescribed, especially after having a PCI. Keep those blood clots down. All right. Then after all is said and done with that, cardiac rehab is usually the next step. There's 3 phases. They all consist with education, support, group and individual support, family support, physical activity. Class is usually 20 minutes. Warm up, exercise, the cardiac monitoring and blood pressure check, cool down. But there's actually 3 phases. So the phases build on accomplishments of the previous phase. Phase 1 is usually in the hospital. That's the diagnosis, essentials of self-care, medication administration, booking those follow-up appointments, when to call 911 if they're at home. Phase 2 is usually they go to a facility 3 times a week. Can be for 2 months, can be for 12 months. Up to 6 months, I think it is actually. Yes. It's supervised, individualized exercise. You do assessment of the treatment, therapy, and effectiveness, adherence. Education sessions. And then it's also multidisciplinary, so they might have a cardiologist come in and talk. The registered dietitian. It might not just be all classroom stuff. They might go to the supermarket and talk about different foods and what to buy. So that's all in cardiac rehab. So going on to the nursing process, the care of the patient with acute coronary syndrome. It's a vital component of nursing care. You want to educate them on being alert of the signs and symptoms about, when they should call 911, when they should come in. Assessing all the symptoms carefully and comparing to their previous and baseline data to detect any changes or complications. We, as a nurse, want to assess the IVs, monitor the EKGs. There's some nursing diagnoses. I think it's pretty obvious. Pain, anxiety, risk for ineffective peripheral tissue, imbalanced fluid volume, anxiety, deficient knowledge. So assessing them, physical, psychosocial, clinical manifestations, IV assessments. There's a bunch of collaborative problems: acute pulmonary edema, heart failure, dysrhythmias, cardiac arrest, effusion, myocardial rupture, blah, blah, blah. So interventions, you might need to give them oxygen to keep the pulse ox up. Vital signs: physical rest, head of bed elevated, or give them, they have cardiac chairs they can sit in. Promoting venous return, at-home care teaching about adopting an activity program, managing symptoms. By day 2, after their kind of episode, they should be able to be pain-free and be able to perform self-care. All right, so some more interventions. All right, so kind of going on to what exactly the PCI is that I mentioned before. If someone comes in, they're having chest pain, door to balloon time 60 minutes. Um, so these are some of the invasive coronary procedures. We'll start with PCIs. Um, so they are going to put in a catheter, and they kind of put it in between the kind of where the occlusion is. They try to put it in there, like between the plaque. Um, so they want to compress the erythema and stretch the coronary artery. So they will open the blocked coronary vessels, and they want to resolve the ischemia and improve the blood flow. So they're going to put the balloon catheter placed in the plaque. Then they're going to rapidly inflate and deflate the balloon, causing pressure. It's kind of like cracking the uh, atheroma. I think I said erythroma before, but atheroma. It also stretches the coronary artery. And then a stent is going to be placed in to maintain the patency of that artery, and then the balloon is removed. And that stent, it's a woven mesh, provides structural support to the vessel at risk for closure. It keeps it in there because if they just took it out, the artery might start to form scar tissue, might start to inflame because it was kind of bothered. So the stent is put in, and we don't want a thrombus to form. So usually they prescribe aspirin and the Plavix or the clopidogrel or whatever it's called, Clopidogrel, Plavix. Um, at least for a month after a bare metal stent, and at least for a year if they have a drug-eluting stent. Sometimes they have a drug-eluting stent, and that's actually shown an increased success of the PCIs, because it can be used to minimize thrombus and scar tissue forming or forming within the lesion. Helps keep the artery patent if they have the stent in there. Eventually, the stent is going to be covered by the endothelium and incorporated into the wall. So removal of the atheroma is called atherectomy. Atherectomy. All right. Okay, the stent. Brachytherapy inhibits smooth muscle cell proliferation by placing a radioisotope close to the lesion. Didn't really go into that, but alright, let's the stent. Alright, so post PCI is similar to post cath care, cardiac cath care. You want to monitor for bleeding, achieving homeostasis. I'm sorry, hemostasis. Positioning and mobility. So, all right. If the patient's gonna be immobile for a little while because they're gonna have that stuff on probably their femoral artery. So it's gonna be bed rest, and you might need to help them feel more comfortable with analgesics and sedation. Patients usually go home the next day if they don't have any complications such as bleeding or hematomas, like a hard mass. So you have to remember that the patients are receiving a large amount of heparin, so you want to monitor them closely for bleeding. That you might need to give them IV nitroglycerin to prevent an arterial spasm, because they were just in there kind of messing around. Hemostasis with a variety of devices. They might have an angioseal, direct manual compression device, a C-clamp, a femstop. So it's just like something that's going to be kind of putting a little bit of pressure on the incision where they went in. It's not really an incision. It's just like a little area where they go in. Sheaths that are left in place upon return to return to the unit. If sheaths are left in place on return to the unit, you want to monitor APTT. Now, APTT, we want to remember that's that thrombo like clotting time. So indicating heparin no longer active and the clotting times are in an acceptable range. That's the APTT test. Indicating heparin is no longer active and clotting time is in an acceptable range. Um, After a few hours, the sheaths will be pulled. The patient remains on bed rest during this time, left straight, manage the discomfort with the analgesics and sedation, like I said. With the sheath removal, you might expect to see a vasovagal response, and that will decrease blood pressure and heart rate. So they may give atropine before to kind of raise that up. If the patient is at risk for a vessel closure, they're usually restarted on heparin. Ambulating within the doctor's orders, usually a few hours post procedure. The time of immobilization depends on the size of the sheath, amount of anticoagulation method, and of course where it is. If it's radial versus femoral, radial you're usually often walking a little faster. Okay, just gonna fly through this other stuff not on the exam. All right. Ooh. Just gonna go over these drugs really quick. So, drug therapy for ACS, beta blockers, and those end in LOL. Well, they end in OLOL, but that's metoprolol, atenolol, propranolol. You want to administer the oral dose within 24 hours of the symptom onset of that pain and continue upon discharge. Don't give it if they're bradycardic or tachycardic, or if the blood pressure is below 100 milligrams mercury, millimeters mercury. Don't use in heart blocks. So again, you just want to monitor for hypotension, bradycardia, signs of heart failure, because it kind of brings everything down, but you don't want it to go too far down. I'm sorry, I didn't mean to say tachycardia. Tachycardia, you would want to use it. It brings stuff down. Beta blocker. But you want to make sure when you give a beta blocker, it will also act on the, like, not only beta 1 receptors, but beta 2 receptors. So that will act on respiratory. So you just want to monitor respiratory. The ACE inhibitors that end in pril, alanopril, captopril, lisinopril, rampapril. Again, administer within 24 hours of onset, assessing for everything that goes down, such as the urine output go down, if they're having coughing, assessing for hypertension. And then we have the statins. Oral dose upon discharge when the low density lipoprotein cholesterol is greater than 100. So you want to take those at bedtime. Statins at bedtime. Prils are ACE inhibitors. LOLs are beta blockers. All right. Okay. And Plavix is also a statin. Oh no, I'm sorry, it's not a statin. Plavix is just another drug, adjunctive drug therapy. Don't give if they have a bleeding disorder. It's supposed to help reduce clots. All right, and that was a little crazy because I'm a little stuffy, but that's it.